Hi, everyone. Welcome back. If you recall, the last time we met, we introduced the concept of adjuvant treatment in the hormone receptor positive early stage setting. We suggested that if a patient has early stage disease that's hormone receptor positive, they are candidates for a breast conserving procedure or a mastectomy. Um, and then after the surgical procedure, depending on certain characteristics of the tumor, the patient may be eligible for endocrine therapy alone, or they might require a course of chemotherapy followed by endocrine therapy. We defined endocrine therapy as the administration of a SERM, such as tamoxifen, estrogen receptor antagonist in breast tissue, and agonist in other parts of the body. You could also administer something called an aromatase inhibitor. There's three of those on the market. And again, too, by way of review, these drugs inhibit the conversion of androstenedione or testosterone into estrone and estradiol. So they suppress estrogen synthesis by tying up the active site. Okay. And if we're going to use an aromatase inhibitor, remember we do that in postmenopausal patients, or if we're going to use it in a premenopausal patient, we also have to administer some form of ovarian suppression or ablate the ovaries in some way, shape, or form. Okay. Now, my question to you is, what is the role of chemotherapy in a patient who has hormone receptor positive early stage breast cancer? Does chemotherapy add anything from a survival perspective, or does it do more harm than good? Do we have a mechanism where we can look at a population of women who have hormone receptor positive early stage disease and sort of, for lack of a better word, handpick the ones that are going to benefit from chemotherapy and avoid giving it to a different subset of patients who are only going to experience toxicities from the chemotherapy and not derive any benefit? Historically, years and years ago, we would just give everybody chemotherapy. It might have helped a subset. It may have just caused harm in a different subset. Nowadays, we have a test that is done on pretty much every patient with breast cancer who has early stage disease. That test is called the Oncotype DX test. And this assay, it's a genetic test that sort of interrogates the tumor to disclose, if you will, certain genes that tumor might be expressing, and that information then lends to the generation of something called a recurrence score. And it helps the clinician predict the risk of recurrence. And this is huge because what we've been able to do now is look at the results of this assay. And we can look at a patient and say, based on the characteristics of your tumor, giving you chemotherapy isn't going to benefit you. Right? You'll get the chemotherapy, you'll get all of the side effects associated with chemotherapy, but giving you chemotherapy isn't going to improve your survival. Opposite to that, we can confidently look at a patient and say, based on your tumor characteristics, I'm strongly recommending adjuvant chemotherapy followed by endocrine therapy. And that all lends to generating this recurrence score. So we'll go over these recurrence scores in a moment, but what I need you to start wrapping your head around is that anybody at present who has a recurrence score of greater than or equal to 26, it's going to be recommended that they get adjuvant chemotherapy followed by endocrine therapy because there is a benefit for those individuals. That higher number, 26, suggests there's an increased risk of recurrence. Lower than 26, it depends. It largely depends on age, and then it depends on menopausal status. And we'll look at that in a moment. But for the most part, patients are going to get diagnosed. They're going to have surgery. If they're going to get chemo based on this information, they'll get chemo, and then they'll move on to endocrine therapy. And this would be in a patient, say, with a score of 26. If it's less than 26 in the right patient, diagnosis, surgery, we skip chemo, and we might go right to endocrine therapy. So let's dissect that down a little bit more here. Where do these numbers come from? What is this recurrence score, and what is the oncotype? It's a 21 gene assay. You have this handful of genes right here. These 5 genes are basically control genes, actin and GAPDH. These are loading controls that we use in Western blots, if you're familiar with that. But there should be stable expression of these genes, and this tells you that the assay is working. Consider everything else that's on here. We have estrogen-related genes. We have HER2-related genes. We have other proliferation indicators. And then we also have some invasion indicators. This MMP11, that's a matrix metalloprotease, and then cathepsin. These are genes that help to digest and break down the extracellular matrix to allow for cancers to spread. If you have high expression of those, that's going to perhaps generate then a higher risk of recurrence score, and then that might indicate a benefit to chemotherapy. Likewise, on that proliferation box, Ki67, we already talked about that as a proliferation protein that you see during replication. And then that STK15, that's a serine threonine kinase. It's also aurora kinase. This is involved during replication as well. Survivin is an anti-apoptotic gene, and then cyclin B1, that's again pairs with cyclin-dependent kinase. Oh, I don't know, one maybe it's later on in the cell cycle. It drives the cell cycle, right? So if you have high expression of some of these genes, or maybe even low expression of a glutathione transferase gene, it's going to impact the recurrence score. So you get the diagnosis, you get a biopsy. Some of that biopsy goes to the Oncotype DX if you have early stage disease. You can generate the recurrence score. And the recurrence score, if greater than 26, we give chemotherapy. All right. Of course, there's different subsets of populations that have early stage disease. We have patients that have N0 disease where there's no nodal involvement, all right, node negative disease. If your patient has N0 disease, node negative, and they are postmenopausal with a recurrence score of 26 or above, we add chemo. It's going to benefit that patient population. If you have a premenopausal patient with a recurrence score greater than or equal to 26, we add chemo because the studies have suggested that there's a survival benefit. If you have a premenopausal patient, younger premenopausal patient, less than or equal to 50 years of age, with sort of this intermediate range recurrence score, chemotherapy in the adjuvant setting may benefit this type of patient, right? Now, when the studies were conducted, there's a little bit of controversy on whether or not the chemotherapy that's administered in the adjuvant setting is actually going out and killing additional cancer cells that might be in the local environment or that may have already spread, or is the chemotherapy acting as a suppressor of the ovarian function itself? Remember, chemotherapy is going to slow down and inhibit proliferating cells, and it can have an impact on the ovaries in a premenopausal patient. So we're still questioning this a little bit. We don't know for certain if the chemo is killing off additional cancer that the surgery missed, or if it's suppressing the ovaries and inhibiting them from making estrogen, right? Node negative disease. What about node positive disease? Remember, N1 disease suggests that your patient has anywhere between 1 and 3 positive lymph nodes. Now, Despite the presence of positive lymph nodes, N1 disease, postmenopausal patients with a recurrence score less than 25 have demonstrated no benefit from adjuvant chemotherapy. Okay, when you have this cohort of patients, postmenopausal patients with 1 to 3 positive lymph nodes and a recurrence score less than 25, chemotherapy doesn't add survival to them. So there's no benefit in giving it. Opposite to that, your premenopausal patients. Premenopausal patients with node positive disease and a recurrence score less than or equal to 25 have shown benefit from adjuvant chemotherapy. So it's recommended in this population, right? N1 disease, premenopausal, recurrence score less than or equal to 25, yes to chemotherapy first, and then endocrine therapy. The invasive disease-free survival was around 94% with combo chemoendocrine therapy versus 89% for endocrine therapy alone. All right. Adjuvant chemotherapy followed by endocrine therapy in those higher risk populations does decrease the risk of recurrence. It does decrease cancer mortality. So we sort of have come to an agreement on when to recommend it and when to hold it. If a patient isn't going to benefit from chemotherapy based on what the data suggests, do we really want to offer it to them and have them go through the torture of getting chemotherapy? It's certainly up to the patient, but the data suggests that some of them are going to benefit and some of them aren't going to benefit. When we use chemotherapy in the adjuvant setting for hormone receptor positive early stage disease, we use regimens like the dose dense ACT regimen, or we use AC with weekly taxane, or if it's a lower risk patient, we can use something called the TC regimen, which is taxotere Cytoxan. We'll look at these in a minute. There are other regimens that are available, but when we're looking at breast cancer in the adjuvant setting, this particular regimen, the dose dense ACT regimen, is probably the most robust and efficacious regimen that has been studied to date. This particular slide with all of this wonderful highlighting on it is derived directly from the NCCN guidelines. And essentially what it does is it breaks down for you once again the recurrence score, the population, and then the recommendation. Here's the recurrence score. Here's the population that we're talking about. Here's the recommendation. Okay. This top sector refers to the postmenopausal patient with 1 to 3 nodes or no nodes, okay? And their recurrence score. Right? And it mirrors basically what I just got done saying. Right? This middle sector refers to your premenopausal patient with no nodal involvement. All right. A premenopausal patient with no nodes and a recurrence score less than 15, no benefit from chemotherapy, right? There's no benefit in giving chemotherapy to that premenopausal patient with a recurrence score less than 15 or equal to 15. Right? They'll do more harm than good. This intermediate group, this is the controversial group in premenopausal patients with that 16 to 25 recurrence score. A small benefit may have been afforded from chemotherapy, but what is uncertain is whether or not the chemotherapy followed by endocrine therapy led to the improvement secondary to suppression of ovarian function or killing off those rogue cells, as I mentioned before. So this is definitely a conversation that the oncologist is going to have with that particular patient. And then again, greater than or equal to 26, chemotherapy followed by endocrine therapy is what's recommended. And then lastly, down here in the bottom sector, You have your premenopausal patient with positive nodes. They have N1 disease, less than 26. Again, the addition of chemotherapy was associated with a lower rate of distant recurrence compared to endocrine therapy alone, but we don't know again if this is secondary to ovarian suppression from the chemotherapy, or did the chemotherapy actually kill off those rogue cells? All right. So this is, again, a conversation point. A little bit less murky is the recurrence score of greater than or equal to 26 in that premenopausal patient with positive nodes. Endocrine therapy after chemotherapy is what is currently recommended. Okay. All right. I know there's a lot of information here. The more we talk about it, the more we practice it, and then the more we reiterate it, it'll become a little bit clearer for you guys. And I'll tell you exactly what I want you to know with regard to assessments. Right. And then again, derived from the NCCN guidelines, these are the adjuvant or neoadjuvant therapy recommendations for HER2 negative disease. When you see a HER2 negative in this box in the guidelines, that's basically saying either hormone receptor positive or triple negative breast cancer. Okay. And it doesn't matter if it's hormone receptor positive or triple negative, the chemotherapy regimens are essentially very, very similar. And for hormone receptor positive disease in the adjuvant setting, which is what we're talking about right now, that dose dense ACT regimen is utilized, although you could also use dose dense AC followed by weekly paclitaxel, right? These are sort of the go-to regimens, right? This dose dense ACT, the every 2 week regimen, that is a very, very aggressive chemotherapy regimen. You're going to give high doses of cyclophosphamide and doxorubicin every 2 weeks for about 4 cycles, and then you're going to give paclitaxel every 2 weeks for about 4 cycles. And when you're doing this, you're giving this patient some growth factor support to make sure that they don't become neutropenic. All right, we need to give them some Neulasta or some Neupogen to help stimulate white cell formation. Okay, all right, moving forward. I'll make one additional point. Abemaciclib, right? Verenzio. This is a cyclin-dependent kinase inhibitor that was studied and initially improved by FDA in the metastatic setting. There was a study done, though, several years ago called the Monarchy study. And this study basically evaluated adding abemaciclib to endocrine therapy versus endocrine therapy alone in our hormone receptor positive, HER2 negative early stage disease patient. Now, this particular study was looking at individuals who had high risk disease. High risk was defined in the study as having 4 or more positive nodes. So it went to N2 disease or N1 disease, 1 to 3 nodes, plus a larger tumor. I think larger here was probably around 5 centimeters. Initially, it was also studied in patients who had 1 to 3 nodes and then a Ki-67 percentage of 20 or above, but I think there were some adjustments made along the lines. Nonetheless, high-risk patients with early stage disease were enrolled and then randomly assigned to endocrine therapy or abemaciclib plus endocrine therapy. What they discovered is that the survival ended up being better in the combination as compared to the monotherapy. So what this ultimately led to is FDA approving abemaciclib in combination with endocrine therapy for high-risk patients. NCCN, N2 disease, or N1 disease with a tumor greater than or equal to 5 centimeters is a recommendation then to use this in the adjuvant setting as well. And keep in mind, I need to make this clear. You have this high risk breast cancer that's hormone receptor positive, right? And remember, high risk is N2 disease or N1 disease with a T greater than or equal to 5 centimeters, all right? And initially it was a Ki-67 of greater than 20%, all right? So those are high risk patients. Right? This patient is going to undergo surgery, right? What's next after surgery? Since they're high risk, they are going to get adjuvant chemo because they're high risk, right? And then after adjuvant chemo, some of the patients are going to get endocrine treatment. Some of the patients are going to get endocrine treatment plus abemaciclib. So this is sort of the investigational arm, and then this is essentially the standard of care. Standard of care, and then investigational arm. And this cohort here actually did better due to the addition of the abemaciclib, right, compared to endocrine therapy alone. So that's why you see this approved to them. Sure, there was more neutropenia, there's more diarrhea, there's increased adverse effects because you're adding on a cyclin-dependent kinase inhibitor, but the survival was better. Invasive disease-free survival was better. Okay? All right. That is what we'll conclude with for right now. When we come back, we will start to talk about our approach to early stage adjuvant therapy in a patient with HER2 positive disease. Right? We will see you soon. Bye.